Hello and welcome back to the Burn Fat and Feast podcast. My name is Sarah Thomas, your host, and today I am honored to be here with Dr. David Rosensweet. And we are talking today all about hormones. This is a hot topic for our community and for our listeners because we are all of that age or almost of the age where menopause happens, perimenopause, menopause, postmenopause. We are in that season of life. And so I'm thrilled to introduce you to Dr. Rosensweet, and we are diving in today to all things hormone related. And Dr. Rosensweet, welcome to the show.
Thank you, Sarah. Good to be here.
Happy to have you for sure. So before we dive into everything hormone, can you tell our listeners just a little bit about who you are?
Well, I've been a holistic medical doctor since 1968, long before there was a word for it. And then about 30 years ago, one of my patients was in great duress. She was in her mid-40s. I had serendipitously, shall we say, spoken to a world expert on progesterone, gave her some progesterone. And 3 weeks later, I got a letter from her saying, "Oh my God, I'm myself again. That stuff is magical." And that was very inspiring to get such a rapid and powerful result. But I wasn't really guiding my practice back then so much. But before I knew it, she had told a lot of folks. And before I started seeing a lot of women in menopause, and then I saw, this is great work. Well, I'm going to specialize in it because there's a lot to this. So I did. And I've been for the last 30 years primarily focusing on treating women in menopause with bioidentical hormones and treating men in andropause.
I love that. I love how something happens in your life. And this is one of my most favorite things on the podcast is that something happens in your life and it leads you down a similar path, but somewhat of a different path. And if that had not happened, you might not be specializing in hormone replenishment. So I'm super excited to chat with you today about that. So, okay. Can we start kind of from the beginning? Because I know a lot of women are wondering, when is it time to start thinking about, looking for someone who's a hormone specialist, or when is it time to start thinking about maybe hormone replenishment in general?
Yeah, great question. My answer really is anytime it comes to you. Now, it comes to many women who are wondering what's going on, even as early as their late 30s, even earlier than that, but certainly in their 40s and definitely in their 50s, because for 80% of women, there's going to be the symptoms. And the hormones are so powerful that those symptoms can be life-altering. So, for example, the hormone progesterone is so calming. So when you lose the hormone progesterone, you start feeling this anxiety out of the blue. You may be used to doing really well with the stresses of life. We all have them. But then it's starting to turn into anxiety. Or lack of motivation from the low testosterone, or you can't sleep, or you're waking up in the middle of the night with hot flashes and night sweats and you're staying awake for a couple hours. Because of the low estrogen that also accompanies it. You get 80% of women are highly inspired to figure out what in the heck's going on. And it's at that moment when you get inspired, you reach out.
Yes.
And the earlier the better. But I've started treating women in their mid-80s to advantage. That's not the ideal way to do it. There's been a lot lost by then.
Right.
These hormones are so part of every tissue and organ in your body. But like I say, whenever it comes to you, that's the best time.
Yeah, it's interesting that you say that. And I agree because I'm almost 46 myself. And so I have felt some shifts in my body in the past few years. And it's funny because I think a lot of women who aren't quite there yet think, oh, well, it's hot flashes. When I start getting hot flashes, then I'll know that here's the change. But for me, it did start with mood changes and some irritability. And that was the first thing that I noticed And I love that you mentioned that, because a lot of women will say, well, something's wrong with me. I just need some anxiety medicine. And so I think that's a really good reminder of like, let's keep digging. Let's look at those hormone changes, because they change rapidly at this time, this season of our life, or my life, I should say. um, so, okay. Can you talk now a little bit about the risks of hormone replacement, or the benefits, both benefits and risks? Because again, here I am. I'm your person, and I personally have been researching everything I possibly can. Of, is it time? What do I do? How do I do it? What are the biggest risks, especially for someone who, like me, is very healthy. I live a very healthy lifestyle, intentionally. And so I want to continue along that path and do all the right things without risking my health in other ways, if that makes sense.
I love that you bring up this question. And 30 years ago, it wasn't much of a question. Women would start feeling changes, would go to their family doctor or their gynecologist. The gynecologist would say, you're in perimenopause, you're in menopause, here, let me give you something for it. And prior to the turn of the century, there was 18 million American women. 40% of those in menopause were on hormones. Mm-hmm. It wasn't a thought. And then out comes, in 2002, this mal-reporting of a study that was being done. And they weren't reporting what was actually going on, but and what they did report was was increased risk for breast cancer, heart attack, and stroke from taking hormones. Well, that wasn't what was in the Women's Health Initiative report. What was in the report is the women on Premarin, horse urine-derived estrogens. They did a lot of good. I'm not trying to knock them. That's not what I've ever prescribed, but it did a lot of good on this planet. There was a reduced risk for breast cancer reported in the actual 2002 version of the Women's Health Initiative. And what was also in that study was there was a 1.26 increased risk for Prempro, which was not Premarin, it was Premarin plus a progestin. There's an increased risk, but that risk was statistically insignificant. Mm. That's what was in the report.
Yeah. Okay. Good to know the details. This is where you need to know the details. Right.
Yeah. In medicine and science, when I see the words statistically insignificant, my wonderful training in medical school said, don't draw any conclusions. Mm-hmm. It's when something is statistically significant that you can begin to change how you're doing things.
Right.
But that's not what the press got a hold of. They just blasted it out there against the wishes of the majority of the members of the committee that had produced that report.
Yeah.
A certain percentage of them didn't want that report to be printed or for the study to be stopped, because they knew it was statistically insignificant. But there was one member of that board that overruled them all, had called a press conference before they had really gone through the due diligence, and the world gets to learn that there's increased risk. Mm-hmm. And so did healthcare providers. And that's all they heard.
Right.
And it scared so many women away and so many healthcare providers away. So most women who go to their doctors and they want to go on hormones, they go, oh no, there's increased risk there. That was 2002. Well, I didn't. I saw the statistically insignificant. I was already treating for 10 years with compounded bioidenticals with great success. I saw the faulty science and I just kept on going. And the committee kept on following up on the women. And in 2006, they knew that 1.26 had reduced to 1. And by 2017, the original committee published in the original journal that after 18 years of follow-up, there was no increased risk of breast cancer, heart attack, and stroke.
Wow.
Zillions of women and providers and men on this planet heard in 2002 that there was increased risk. Almost nobody, now there are some exceptions, have heard that original report was, that original pronouncement was retracted by the original committee. People are still going off of there's
Right.
increased risk. If you look at package inserts on estrogel, for example, a pharmaceutically manufactured, not my favorite, but it just scares you because you think there's increased risk.
Yeah.
Now, what I'd like to do is share the science with all your listeners, the
Please
actual
do.
science. And of
Please
course,
do.
if you want to see a good summary of that, you're going to post a link to a free PDF version of my book. And in chapter 3, I go into this into some detail. And then there's a Bible out there, a book called Estrogen Matters, that is published by a oncologist who specialized in breast cancer, Avram Blooming and Carol Tavris. And it's the real deal about, for a woman who wants to really know what's going on, read that book. But here's the science. We are all human beings at risk for thousands of medical diagnoses, and we'd rather not have any of them because some of them are not good at all. We're at risk for hundreds of cancers. And as a male, I'm at special increased relative risk for prostate cancer. Didn't used to be that way, but it is now these days, and there's reasons for that. And women are an increased relative risk for breast cancer. Didn't used to be that way when I was in medical school. Now it is. There's definite reasons for it. So we're all at risk. And given those risks, let me tell you what the actual science is. Women who are treated with hormones are at less risk for breast cancer, heart attack, stroke, and dementia than women who are not treated with hormones. Women who are treated with hormones, I'm repeating myself, I realize this.
Please do.
This is the science. You can dive right in as deep as you want through my book and through Dr. Blooming and Dr. Tavris's book. Women who are treated with hormones are at less risk for breast cancer, heart attack, stroke, and dementia than women who are not treated with hormones. It even goes so far as women who've had breast cancer, because there is the risk out there, and there is women getting breast cancer. Women who have had breast cancer and had that breast cancer properly treated, well, they happen to be at an increased relative risk for recurrence than a woman has for getting breast cancer who's never had it.
Right.
But women who have had breast cancer, had that breast cancer properly treated, they're at less risk for recurrence if they're treated with hormones than if they are not. That's the science.
Okay. Thank you so much for sharing that. That's pretty significant, I would say.
Yeah.
Wow. Okay. So then for all our listeners, they should feel pretty positive about hormone replacement, about doing something to fix their hormones as they get older. All right. So then so let's say here we're ready, to do something about it. We've got low progesterone, and maybe that's where we're going to start. And so what would you say is the best type of hormone replacement, in terms of, I know you mentioned bioidenticals, but in terms of like creams or pills, or is there something that we should look for one or over the other?
I'm going to approach this in a slightly different way.
Okay.
Because hormones are prescriptive items, you need a licensed healthcare provider. So when you start sensing that, it might be my time, in this day and age, it's still pretty good for a woman to get a basic education. And that's why I recommend that you read my book, or there's a lot of books out there on menopause. However, your primary job is this. It's to go shopping and find a healthcare provider in your state because of telemedicine. You don't need someone across the street from you or in your town even. You just need someone licensed in your state that really loves hormones, have really dived into this, has a certain level of extra training because you need it. We don't get this in medical school or residencies. You find someone that you really like and you trust that is prescribing and doing this work. And that's your main job.
Mm-hmm.
Find them, link up with them, and let them co-create the process with you. Now, part of finding them and what's going to matter to you is you not only see that they're well trained, you like them, and you can talk to them, and you can do it together because you're going to have to do the best work.
Yeah.
And it's one of the things I point out in my book, is that women and men, we're so individual. We look like men and women, but we vary enormously for a lot of so some women need this much estrogen, for example, to do really well, to be young and fertile and healthy and carry a pregnancy to term. Other women need 3 times this much.
Mm-hmm.
And then there's everything in between. Well, clinically, it's not a problem. We start out with low and we gradually increase until symptoms are alleviated. And if we go too high, we'll get symptoms of overdose when we back down. But you need to get individualized for best work. Now, having said that, my God, if the only hormone that I had to work with was Premarin, I'd do it. But it's gotten the years of Premarin, these were developed in the 1940s. This field, like automobiles or computers or the internet, has progressed enormously over the last 50 years.
Right.
So, yes, you could use a calculator rather than a computer or an iPhone, but you'd probably want to take advantage of the tremendous advances that have taken place. And so the very best stuff is compounded bioidentical hormones.
Mm-hmm.
You cannot achieve the individualization and precision that you're going to want as a woman.
Yeah. Okay.
Without doing compounded bioidentical hormones.
Yeah.
You can achieve stuff that's good, but the best is, and you're going to want the best, for God's sake, we're all going to, once we start taking these, we don't want to stop taking them for our 10, 20, 30, 40, 50 years we're on Earth.
Right.
No one's going to separate me from my compounded bioidentical.
As you have them
maybe I
in
can't
arm's
take
length.
a cap off or something. You know?
I love it.
So the precision and the individualization is achievable by physicians and nurse practitioners and PAs who are prescribing through compounded pharmacists. Mm-hmm. And they've been doing it for 50 years. They know it really well. And so that's what everyone's going to want the best.
Yeah.
And you can achieve it that way.
Okay, so I have a question about looking for a provider. I personally have an excellent provider who I love, but I do know many women ask me about my provider, or people in other states ask me what to look for in a provider. So what would you recommend when you're searching for a provider other than someone who, specializes in hormones? That I have found through other women that there are, and maybe it's just because they're not hormone specialists, but there are lots of doctors out there who will just say, well, you're okay. We won't worry about it right now, even if those hormone levels are off.
They're not in menopause. They would never say that. In fact, it points to one of my favorite, the main thing I do is I teach and mentor physicians and nurse practitioners on how to specialize in this, how to do great work. And who are my favorite physicians and nurse practitioners? Women in menopause. Because they know.
Right, exactly.
And when a 35-year-old young doctor comes to me, well, we're very grateful. They're going to have a longevity. Mm-hmm. But they're not as determined or inspired as a 50-year-old physician or nurse practitioner who's in menopause and has already been treated.
Right.
they know what is going on here, and they know how important it is.
Yeah, that's
So that's
great.
one of the criteria.
Yeah. That's great advice. I would
Yeah.
100% agree. Yeah.
And there's other ways to do it. Ask your friends. What I said is your main job as a woman or as a man is to go shopping
Yeah.
and to use the level of scrutiny that you do for anything that matters for you.
Yeah.
And one place to start is with your friends. If you haven't talked to them and they look your age or older, many of these women are going to be on hormones.
Yeah.
And if they look real good and they're in their 50s and 60s, these are the ones you want to talk to because they are on hormones, most of them. And what do you want to ask them? Do you like your provider? Do you like the care you're getting?
Yeah.
Because a direct referral, there's nothing better than that.
Yeah.
Yeah,
I agree.
my nurse practitioner, she's been well trained. She's deep into this. She's moving towards specializing in this. She uses compounded bioidentical hormones. That's number two. You want someone who has chosen to prescribe compounded bioidenticals because they're going to be capable of writing individual prescriptions for you that are going to be able to meet in a precise way your individual needs and balances. So the other key word is they are prescribing compounded bioidenticals.
Yeah.
And the other thing, there's other ways to do it. I mean, you can go to our website, bright.live. We've trained people all over the United States and in other countries, and they're following our method. So if you download our book, you'll see what our method is, and you can get referrals just by contacting through Bright.live people that we've trained. Now, those are the ones I love and trust the most. I'm spending time with these folks.
Yes, absolutely.
And I know what our basic training is, and I know about our grand rounds, and I know the depth in which we're going in. So Bright.live can get you there. Here's another way to do it. There are 7,500 compounding pharmacists in the United States. And what I recommend is that you actually walk into your local one. If you call them on the phone, you're not, they're busy folks and they don't know you. They can't see you. They don't even know you're a human. You could be a bot, bro. But if you walk in there and ask to speak to the compounding pharmacist, and most of them are so gracious and such lovely people, and they're the ones who care tremendously about pharmacy and compounding. I'm not saying that there aren't traditional pharmacists that aren't great people too. But the compounding pharmacists are going to be the ones who are receiving prescriptions from physicians in your area.
Yeah.
And nurse practitioners, they're going to know how good they are. And if you say, I'm in perimenopause, I'm in menopause, I would really love to get your opinion about what provider would you think is doing the best work around here.
Yeah. That's a really good way to go about it. I've actually never thought about that before.
Yeah,
Great
that's a
idea.
good one. And there's all kinds of ways, but those are the three best. I would say go to our website, bright.live, talk to your friends, ask what they're seeing.
That's great advice.
And unless your friend is saying, oh man, I love what I'm doing and I'm on compounded bioidenticals and I love my provider.
Yeah.
Unless they're saying that, you may want to go shopping for who they're using.
Right.
But you want to keep going because you're going to want the best.
Yeah. So I have a question for you, and this is just because I don't have the knowledge of telehealth. And so if, let's say, so I'm in Nashville, Tennessee, I can or cannot see someone in another state.
Things are changing rapidly.
Okay.
But let's look at that excellent question. Number one, officially, in order to get a prescription, not everyone is following this degree of precision, but the national pharmacies are the ones that are licensed in 50 sites. They want to see your driver's license, which is going to be your proof of residency, And they're going to want to receive their prescription from a physician or nurse practitioner or PA who's licensed in your driver's license state.
Okay.
That is the official, highly compliant way to do it.
Okay.
Now, the things are changing so fast that they used to be a lot more loosey-goosey about this. Now, here's what it was like for me for most of my career. So long as a patient would fly in to Florida, where I was, or New Mexico, where I was, and see me once in person a year, they could go back to their state, and I could write prescriptions to their state, to a pharmacy, a local compounding pharmacy near them. And I could conduct everything by telephone, which translated later to Skype,
Right.
and then to Zoom, and then to a HIPAA secure Zoom, which we use now. And that was perfectly fine. This environment is changing. And I told you the most stringent, and we're learning every day, and it's changing every day.
Yeah. Okay. Good to
So
know.
it is the question you ask, but because you could gain access to the best in the country if you're willing to fly in once, because that was the official requirement. For example, Florida, it was fine for me to treat someone out of state, but the patient had to fly in from out of state and sit in my office once, and once a year, and then it was fine for me to treat them if they were out of state. Changing environment, though. So the best thing you can do is find someone in your state who's really well trained, really cares about it, really knows what they're doing.
Right. Yeah. Good advice. Yeah.
The
I was
only
just,
other thing
I was
I'd like to
curious.
add, excuse me,
Yeah.
but I think you're going to want to know this, is that so long as you have a primary care provider that you can see in person should the need arise, or for your annual visits, telehealth works spectacularly for women in menopause and men in andropause to handle that part of their health thing.
Right.
It's fantastic. You do not have to get in your car and drive to someone every time you've got an appointment.
Yeah.
You do for some things. You got pain in your lower abdomen, you got to go to someone right close to you as quick as you can get there. But not for the hormone work. We can learn everything we need to know through telehealth. Now, part of our method includes you must have a relationship with a primary care provider in which you can get an annual exam, or with a gynecologist. That's part of how we'll work with somebody. But telehealth will do all of what you need, which opens it up to anyone in your state. Now, Nashville's a pretty big place.
Right.
And you probably could find someone in the Nashville area.
Yeah. I'm just, I was really curious about that because I've heard varying things of yes, you can, no, you can't. And I'm assuming the inconsistency that I've heard with telehealth is like you have said, that things are changing rapidly of what, you as a provider can do or you can't do. And I have a lot of our members who are across the country that are not in my state asking about recommendations. And I wasn't sure exactly what, the rules were along those lines of telehealth and what you can do and can't do and your state requirements. So
there is one more caveat.
Okay, let's hear it.
Getting down into the weeds. Because every single woman needs testosterone. There is no exception. Or there might be one or two exceptions. I can think of them in my practice. And it's imperative that you get testosterone because it is not a male hormone. Young women have twice as much testosterone. It has the most potent estrogen, estradiol. And really, in the long run, over the course of your life, you're going to want to, because I work with 70, 80s, and 90-year-olds. And as a physician, I see women in their 70s, 80s, and 90s. And I know what happens. They lose their muscle. And they go from cane to walker to wheelchair. Ooh, that's a significant change there.
Yeah.
And many women lose the ability to hold their urine, so they get into adult diapers. That's a big one. And many women lose their cognition. But as far as muscle and bladder health, you must have testosterone or you lose your muscle. And yes, exercise is fabulous and imperative. You don't get to stop exercising. In
That's
fact,
right.
you want to get you want to be an expert at it
Mm-hmm.
for your own self,
Right, right.
or otherwise known as you do it. That's an expert.
Yes.
Just do
Just
it.
practice it daily, right?
Do it. But you also need the androgens,
Mm-hmm.
testosterone.
Yeah.
So testosterone turns out to be a controlled substance, just like narcotics are, because of abuse that was done
Yeah.
by muscle builders. Now, this is all under review. And best case scenario is they're going to stop calling testosterone a controlled substance for women in menopause and men in andropause. But we don't know that. It's under review right now. And part of how testosterone is controlled is that you must have an in-person visit
Mm-hmm.
once a year. So because it's a controlled substance, so some licensed provider will see, oh, you are a human and I know you and I'm writing a prescription to someone I've met.
Yeah.
And it's not just going through the internet.
Right.
So the DEA had reasons why they made it a controlled substance and why they insisted upon a yearly visit so that you can tell it's a human.
Mm-hmm.
Now they've waived that because of COVID. And currently, and at least till December of 2024, you don't have to do that in-person visit. But we're going to see what's going to happen in December of 2024, where they're going to reinstitute it. So it's handy to have someone in your state.
Yes. Yes.
Although we're going to see what kind of, how stringent are they going to be? Are they going to allow, just so long as you meet up with a nurse, for example, that is in your state, that and you take a selfie with the nurse because then they know you're human. We know you're
Yeah.
human. So it's to be determined. But right now, you could do it with anyone in your state and do it by telehealth.
Yeah. Okay. Okay. Good to know. Lots of things that are to be determined. It sounds like on that end as well. This is great information. I think that all this is super valuable to a lot of our listeners who are starting to think about hormones, just don't have a whole lot of information regarding who to look for when they're looking for a specialist. So this is a great place to start for them. Now, I know you mentioned you had a book that we would be able to share the link for. What is the name of that book?
Happy, healthy hormones.
Happy Healthy Hormones. I like it. So we will leave the link to that in the show notes. Definitely something that I will be looking into, as a lot of our listeners will as well. And then tell us where else we can find you as well, David.
Well, it best place to find me if is on bright.live. Unless you're a healthcare provider and you're interested in our training program, and the best place to find us there is in iobim.org. The Institute of BioIdentical Medicine, that's the organization in which we do all of our training. That's IOB as in boy, IM as in Mary, iobim.org.
Okay. Okay. That's for healthcare providers.
That's it.
Correct.
Yes.
Okay. And then Bright.live is where we can learn more about providers and then
Bright.live is for potential patients.
For patients. Perfect. Perfect. So we will definitely leave that in the show notes as well for our listeners. Thank you again so very much for your time. This has been very, very eye-opening. I appreciate you being here with us and sharing all your knowledge.
You're so welcome.
And we look forward to having you back again,
I'd be honored.
Dr. Rosensweet. Again, thank you.
I'd be honored, Sarah.